Okay, our next speaker is Professor Michael Hofman, as extensively introduced yesterday. He is a nuclear medicine physician at the Peter MacCallum Cancer Care in Melbourne, Australia. It's the only public hospital dedicated to cancer treatment, research, and education. He has a co-appointment at the University of Melbourne and previously completed a fellowship at Guy and St Thomas Hospital in London. He's the director of the Prostate Cancer Theranostics and Imaging Center of Excellence at Peter Mac, and his research is focused on novel radionuclides for imaging and therapy, including preclinical and phase 1 to 3 clinical trials. He led landmark clinical trials of PSMA, imaging and therapy, including Pro-PSMA. He has authored and co-authored more than 220 peer-reviewed articles and is an inaugural scientific member of the Australasian Radiopharmaceutical Trials Network. He's an editor of several international journals, including the Journal of Nuclear Medicine, European on Urology, and Cancer Imaging. He's going to be talking to us about combination therapies and trials. Thank you so much, Prof. Hofman. You may take the stage.
Thank you. It's a real honor to present in the final session of the conference. It's been a real pleasure coming here and seeing how rich and diverse the South African nuclear medicine community is. So I'm going to be talking today about clinical trials and many combinations and earlier use of PSMA therapy, and it's a really good segue into the previous talk on ethics. Here are a few of my disclosures. So when we did our first PSMA PET-CT back in 2014, now almost 10 years ago, it was kind of immediately obvious that it was a lot better than CT, MRI, bone scan. Here is an example of a patient with a primary prostate cancer and extensive pelvic nodes, all sub-centimetre, just tiny dots on the CT. So do we really need a clinical trial? It's just obvious that it's better. Why bother doing a clinical trial? And indeed, I think when I did nuclear medicine training, there was not much of a culture of clinical trials. We would look at these pictures and actually say, a clinical trial is unethical. The images are obvious. Why would you study this in a randomized trial? But I've come to see the value in clinical trials, because if we truly want to change patient management, we need to show that this results in positive outcomes for the patient. Some people would look at this scan and say, well, we don't know what these dots mean. Maybe we should still remove the prostate gland because this test is too sensitive. Maybe we would misguide our management if we believe this scan, even if the results are real, because we know from experience, based on CT, that doing a prostatectomy in this patient would be valuable. So why should we change? So I think we do need to study this carefully. And even in Australia, where we have a lot of health resources, government will not fund a new scan just because we show pretty pictures. They will demand high-level evidence. So we went on and we did the Pro-PSMA study, which was a 300-patient study. We randomised patients to either a PSMA PET or CT bone scan at 10 sites around Australia, and we showed superior accuracy, higher management impact, and a lot of other secondary outcomes. You know, this was published in the Lancet in 2020 and already has more than 1,000 citations. So I think the impact of clinical trials is real, because this is now incorporated into multiple practice guidelines. So I want to take a moment to thank Mike Sateche for he was the pull for me to come here to this meeting. But I also have a challenge for Mike, which is that I think you can do clinical trials like this in South Africa. And it's maybe not a challenge for Mike, but it's a challenge for everyone in the room, and particularly the young people, the next generation, because Mike's achieved an incredible amount in a short life. He's almost achieved the impossible, right? Doing clinical trials like this, publishing in the Lancet, it is possible, and it's the young people that'll take that challenge on and go on and do it. And the wonderful thing about doing clinical trials is you end up with this population that you can continue to follow up, and you can get not one paper, but you can get 5, 6 really high-quality papers from one clinical trial. So we continued to follow up the pro-PSMA cohort, and we looked at the value of a negative PET scan. If a patient had no evidence of distant metastases, in 4 or 5 years later, how many developed distant metastases? So the trial didn't end with that Lancet publication, and we've recently looked at the results of this, and currently under peer review actually, but we showed that if you had nodal metastases on the PET scan, like in that first slide, that 5 years later, indeed, much more patients were failing with distant metastases. Whereas conventional imaging, which you can see on the right, showed no difference. CT scan was unable to prognosticate in this way, telling us that those small nodes that we see on the PSMA PET scan are indeed significant. For those coming to EANM, I'm presenting this one in more detail at EANM. And the other great thing about doing a clinical trials is we create a real network of people working together. And you don't have to do this. You can do a very small single-centre trial. Our first lutetium PSMA trial, only 30 patients, but had a high impact because it was done prospectively and well. But if you want to do a big trial with a few hundred patients, then it must be multi-centre. And the other feature of this is that it's not just nuclear medicine. It's nuclear medicine working with medical oncology, urology, radiation oncology, and also clinical trial staff. Unfortunately, we need trial coordinators, we need some assistance, we need the biostatisticians to help us with this work as well. And this group of people that's now established is like an army doing lots of clinical trials. Maybe Helen had a better word, a village of people working together. So we've now got more than 10 investigator-initiated trials of PSMA theranostics. So I started with the Gnostics, the diagnostics of theranostics, and the rest of the talk will just be highlighting some trials of PSMA therapy that are underway in Australia. So the first one is the Violet study. This is a small 30-patient trial, phase 1-2, using terbium 161 PSMA INT. So with lutetium or even actinium, we see that complete responses are rare. Eventually prostate cancer comes back, and this seems to be a limitation. And perhaps this may originate from our inability to eradicate micrometastases, particularly with beta radiation. Path length of 1 millimetre, we get a great crossfire effect, but we don't eliminate the last cell. If we do a thought experiment and we get down to that single last cell with lutetium, the beta ray travels 1 millimetre, hits normal tissue nearby, but not the last tumour cell. Terbium 161 emits beta radiation, very similar to lutetium 177, but also emits Auger electrons that travel less than the width of one cell and will hopefully increase our ability to kill these micrometastases. At least the preclinical data suggests that this is the case, but we really need to test and prove this. So we've embarked on this small trial. We're taking patients who are really suitable for lutetium PSMA and asking them if they want to participate in this trial of terbium. We're giving up to 6 cycles separated by 6 weeks, and we're uncertain of the toxicity profile of terbium. So we've started gently with 4.4 gigabecquerels and had 3 patients in each dose cohort, and we're currently in the highest dose cohort of 7.4 gigabecquerels. I think we've just treated patient number 15 on this trial, and so we're now in the dose expansion cohort, and it seems to be well tolerated. Here's a picture of a patient from the trial. You can see the gallium PSMA on the left, and then 3 time point terbium SPECT CT for 24 and 96 hours. We can see washout from the physiologic organs, salivary glands, kidneys, and nice retention or even accumulation of the terbium in sites of disease. Here's a sub-centimetre lymph node in the para-aortic region, and we can see actually the intensity of uptake increases up to 72 hours. So this is very promising. Again, we have a presentation of our normal organ dosimetry in this study at EANM in a couple of weeks' time. Going to be presented by one of our nuclear medicine technologists, Brittany Emerson. Switching to another trial, this is a trial run by ANZUP, which is a cooperative clinical trials group called the ENZA-P trial. In this trial, run at 10 sites, we randomised men pre-chemotherapy to either enzalutamide or combination of enzalutamide plus lutetium PSMA. And we embedded a lot of PSMA PET at multiple time points. So some of you will know that in the castration-resistant setting, we can see upregulation of PSMA, increased intensity, after we start enzalutamide. And this trial really looks at this in some detail in addition to treating patients. So here's a slide from Louise Emmett showing this upregulation phenomenon. This is a patient from the trial. Baseline PSMA PET, PSA was 140, and then at day 15, so 2 weeks later, the patient has a repeat PSMA PET, and you can see the PSA is already declining from 140 to 98, but the PET scan paradoxically looks worse. Increased intensity, even additional sites of tumour visible. And as part of this trial, at that point is when the lutetium is started, after the upregulation. And you can see at day 92 an undetectable PSA with a normal-looking PET scan at day 92. This trial is now finished recruitment. I can tell you the first analysis has actually been done, may be presented at our oncology meeting in a few weeks' time. Another trial we have running is the LUCAB trial. This is a smaller trial, just Peter Mac, single centre, phase 1-2. In the therapy trial, we saw that lutetium was better than carbazitaxel. We saw better PSA responses, better progression-free survival, but actually overall survival wasn't improved. And it was evident in that trial that carbazitaxel was quite effective. And we asked the question, what about if we combine the two? Because in the therapy trial, many patients ended up having both. They had carbazitaxel on the trial and then afterwards had lutetium, or if they were randomised to lutetium on the trial, after finishing the trial, they then went on and had, carbazitaxel. And we know in patients with aggressive prostate cancer, they're still dying from this disease. So can we do better if we combine carbazitaxel and lutetium at the same time rather than sequencing? And the theory here is that carbazitaxel will do two things. One, it will target the PSMA negative cells, and two, it's a radiosensitizer. Taxanes are potent radiosensitizers, so it will disable the tumour's ability to repair their DNA after radiation damage, and we'll get additional effect from the lutetium. Again, this is a small trial focused on safety and some early efficacy signals. We are worried that this combination might be toxic, so we're doing it carefully with a standard dose of lutetium and then increasing the dose of carbazitaxel from a sort of half dose of 12.5 milligrams per metre squared up to the full dose, which is the 20 milligrams at the bottom. And we're currently at the 17.5 milligram per metre squared dose, and it seems to be well tolerated at this dose. Different side effects actually between the two drugs. Another combination trial we're running is the alpha-BET trial, combining alpha and beta radiation, like Mike has already done, but with different radionuclides. So here we're combining radium-223 with lutetium PSMA INT in this study. And the concept here is that when we treat with lutetium PSMA, most of our failures seem to be within bone. We see very good soft tissue responses. Often the nodal disease, even visceral disease like lung, even brain metastases disappear completely and don't come back, but patients seem to progress within bone marrow. So prostate cancer likes growing in the bone marrow. It's like a fertile soil for prostate cancer. So the question here is, if we add in radium, a bone-seeking radionuclide, can we increase the durability of responses, particularly in marrow? This is based on some preclinical data showing that the combination is perhaps more effective than either alone. So here in a mice model, you can see when you give radium and lutetium together, the effect is far superior than either the radium or the lutetium given alone. So similar schema to our other trials, we're giving a standard dose of lutetium, 6 cycles separated by 6 weeks, and dose escalating the radium, starting at a half dose of radium and then going to a full dose of radium. And this trial's progressing well as well. We're at the full dose of radium. We're now in the dose expansion cohort then there in this study. Again, the toxicities appear non-overlapping, so it's quite easy. We give them both at the same time. So one visit, we give the lutetium, and then we give the radium. So no extra visits for the patient. This trial presented by Shanine Sandhu, one of our oncologists at ESMO last year, is the PRINCE trial, combining lutetium PSMA 617 with pembrolizumab, which is a PD-1 inhibitor form of immunotherapy. This was a small trial, 37 patients. It's now completed. The results looked promising. PSA response over 50% was 73%. And whilst we didn't see any increased toxicities from either what we would expect from pembrolizumab or lutetium PSMA, I can tell you we do get a lot of side effects with immunotherapy, so it can be problematic to deliver. We've gone on to do the Evolution trial, which is an even more intensive regimen of a CTLA-4 inhibitor, ipilimumab, plus a PD-1 inhibitor in combination with lutetium PSMA 617. That trial's actually finished recruitment, and I can tell you we saw a lot of toxicities in this study. And maybe in a sentence to summarize, I'm not a big fan of immunotherapy in prostate cancer. I don't think it works very well. It's very expensive, and we see too much toxicity. A more interesting combination is LuPARP. Now, this is a trial where we're adding in a PARP inhibitor to lutetium PSMA 617. So some of you will know that some prostate cancers have a BRCA mutation, and olaparib or other PARP inhibitors are approved drugs that inhibit DNA repair and can be very effective in patients with these inherited mutations of DNA repair. In this trial, we're just giving the PARP inhibitor to all comers, not just patients that have a mutation, and we're using the PARP inhibitor as a radiosensitizer to inhibit the repair of radiation damage after delivering the lutetium. We were quite concerned that this would be a very toxic combination because we know in studies of external beam radiation with PARP inhibitors that patients can get some really nasty toxicities from external beam once you add in a potent radiosensitizer such as a PARP inhibitor. So we started at a very, very low dose of olaparib, and we had a very slow dose escalation schedule. And initially we gave the PARP inhibitor starting day 2. We did this because when you give lutetium, it washes out of the blood, it washes out of kidney, salivary organs, but it sticks to tumour. So if we started the PARP inhibitor on day 2, we would get the radiosensitizing effect in tumour and minimise damage to any normal tissue. So it's quite a clever way to maximise the effect of radiosensitization in tumour. And this study is now at the highest dose level. The results were actually presented at ASCO this year in the middle of the year, the big oncology meeting, and it seems like quite an encouraging combination. Not much increased toxicity. Here's the waterfall plot of PSA responses. We did see good responses in these small trials. It's really difficult to ascertain whether it's superior to lutetium alone, but we can say unequivocally that this combination is quite safe. And much really to my surprise, when we give this combination, we really don't see any increased toxicity with the patients in front of us. They seem to tolerate the treatment just as if they were having lutetium alone. And we've also embedded a lot of biomarker analysis in these clinical trials. So we have a lot of secondary analyses to be done. So these patients had PSMA PET scans every 12 weeks. We can do a lot of quantitative analysis of these PET scans. They've also had bloods taken for circulating tumour DNA measurement, which we can see on the graph on the bottom right. So we've got this really rich data set with outcomes, and we can now go back and look at the PSMA PETs and the circulating tumour DNA and see whether there's particular subgroups of patients that respond to the treatment. Another interest has been not just combinations, but moving from a last line of treatment to a first line of treatment. I think Mike's leading the world in doing this. You've already treated patients that are chemo naive or even prior to hormone treatment. One trial of interest that we've now finished recruitment now in the follow-up phase is the upfront PSMA trial. In this trial, we're taking men with newly diagnosed prostate cancer with high volume metastatic disease defined on a PSMA PET scan, and we're randomising them to either standard of care, which was hormone treatment plus docetaxel, or the experimental arm, which was 2 cycles of lutetium PSMA 617 in combination with ADT, followed by the standard of care docetaxel. And the primary endpoint in this study is an undetectable PSA at 12 months. And we're hoping that by adding the lutetium, we'll increase the number of patients. The protocol for this is published, so you can look that up. Another benefit is we've got a lot of PhD students out of these trials across multiple modalities. We've got a urology, nuclear medicine, and medical oncology PhD students working on these trials. So it's another added benefit of doing clinical trials, and we should have the results of this trial sometime next year. Here's a patient from the upfront PSMA trial. We can see PSMA and FDG PET at baseline, and after 2 cycles of lutetium PSMA, a complete response in this patient on both PSMA and FDG PET. So I think this looks like a promising approach to add in lutetium very early on. We've also done this small trial of 20 patients called the lutectomy trial, where we give lutetium in patients with newly diagnosed high-risk localized prostate cancer prior to having a prostatectomy. So in this trial, we took men with SUV over 20 in the prostate cancer. They were allowed to have pelvic nodal metastases, but no distant metastases. And they had, the first 10 men had 1 cycle of lutetium, and then 6 weeks later had prostatectomy. And the second 10 men had 2 cycles of lutetium and then proceeded to prostatectomy with a pelvic nodal dissection. The primary endpoint of this study was actually absorbed radiation dose. How much dose could we get to the prostate cancer? Because we know that external beam radiation is a curative intent option for patients with localized prostate cancer. And really the question we're asking here is, could we use lutetium PSMA instead of external beam maybe in the future? If we can get very high doses to the prostate tumours, can we use it instead? Or can we use it in addition to surgery or radiation? Here's an example of a patient from this study. This is a partial volume corrected dosimetry map. Some of these tumours were quite small, so we measured them on the MRI scan, and then when we had the volume, we could do some partial volume correction and produce some images like this. So you can see it's quite remarkable to give an intravenous dose of a radionuclide and see it concentrating in the prostate gland like this, almost no uptake to normal tissues. This patient received 115 gray to the prostate primary tumour from a single dose of lutetium PSMA 617, and very low doses to normal tissues. You can see 2 gray to salivary glands, 0.1 gray to bone marrow. So this does seem to be a promising approach. This trial's now finished. It was presented by one of our urologists at the European Association of Urology meeting earlier this year. It's been submitted to publication. It's currently going revisions. It should be published any day now. And remarkably, the surgery is easy to perform. So when our radiation oncology colleagues give external beam to the pelvis, it's quite challenging for the surgeons to go in afterwards and try to operate. There's a lot of fibrosis of surrounding tissues. But when our surgeons went in after a dose or 2 of lutetium, they found a very clean field. The very short path length of lutetium made the surgery, no more difficult than previously. And we measured this very carefully in the study as one of the endpoints. Here's Declan Murphy with a prostatectomy specimen after a robotic prostatectomy. He's head of our urology service. We call him a nuclear urologist, and I met a nuclear urologist here in South Africa as well that was very into nuclear medicine, so that was really pleasing. I'm actually presenting the results of the lutectomy trial also at EANM in a few weeks' time, so if you want more detail, come and join us for that one. So I think take-home messages are that clinical trials are the best way to change paradigms. With nuclear medicine alone, we can help a lot of individual patients, but we can't change the world. And if we produce retrospective data and publish it in nuclear medicine journals, it tends to be only nuclear medicine doctors that adopt the technology. And in order to really change clinical practice, we need to do prospective clinical trials together with our clinical colleagues. And there's many trials of PSMA theranostics underway. There's several more beyond what I've shown in this. This is just the Australian trials, but there is a lot of international industry-sponsored trials as well. So lots of promising combinations. I think combinations is the future for PSMA theranostics. We do need to do better. And there's lots of new isotopes that are interesting as well. And bringing it earlier is going to be a game-changing approach as well. So thanks again for the invitation. I need to run away after this talk, so I won't be here at the end. But please, if you have any questions, do send me an email. And maybe come and visit us in Melbourne next year. We're running a PSMA teaching course called PROSTIC 24. It's 14th to 16th of March. It's a very interactive conference. It's only 2 days, but it's very intensive. And we have a lot of case discussion where we look at PSMA PET scans together, and we look at cases of lutetium PSMA therapy. And we go all the way from easy cases to really, really tricky cases. So hoping to see a lot of South Africans in Melbourne next year. And thanks again for the invitation.
Thank you so much, Prof. Hofman.